Thank you all for coming tonight, and I want to first say thank you very much to the students who really put this on and got this all organized. They did an amazing job, obviously, of publicizing this discussion. I'm Brian O'Sullivan. I'm professor of pediatrics and also director of the Core for Bioethics at the medical school. I'm serving as moderator tonight, Jim Lair or whatever, if you will, because this is a presidential debate, and I hope there'll be no rancor from side to side. Just a couple things I want to say first, and of course the students picked Halloween for this tonight to do this, which actually is the day before the Day of the Dead, which since our topic is what it is, I somehow thought it was appropriate to at least mention it. So you've got in your hand, those of you who got the little handouts have this, but I just want to make sure we all know what we're talking about. So when you go to the polls in a week, this is what you're going to see on the ballot. So I'll read it along, and you guys can all read, but I'll read just so we all know it. It is hereby declared that the public welfare requires a defined and safeguarded process by which an adult Massachusetts resident who has the capacity to make healthcare decisions and who has been determined by his or her attending and consulting physicians to be suffering from a terminal illness that will cause death within 6 months may obtain medication that the patient may self-administer to end his or her life in a humane and dignified manner. It is further declared that the participants, including the patient, his or her physicians, and any other healthcare provider or facility providing services or care to the patient, entirely voluntary, I'm sorry. This act being necessary for the welfare of the Commonwealth and its residents shall be liberally construed to the effect of the purposes thereof. And a yes vote would enact this proposal, a no vote would make no change to the way the laws in Massachusetts are now. So I just want to review a couple of the conditions. I know our panelists will be talking about this some, but we're talking about patients who have to be mentally capable of making a decision. They have to be diagnosed with an incurable disease with the prognosis of death within 6 months, and there have to be 2 physicians who agree on this, so it's not just one doctor saying it. The patient has to voluntarily express a wish to die and has to be able to communicate this twice with at least 15 days in between the 2 times. The physician who's prescribing can refer the patient for a psychiatric evaluation if the physician believes the patient has impaired judgment. And I've highlighted the word if there, it's not mandatory. And obviously participation is voluntary for both the physician and the patient. This is not dictated as something that has to be done. And just because a lot of different terms have been used for this, some people call it physician-assisted suicide, and I think that's perhaps the most commonly used term. Some who don't like the term suicide have called it physician-assisted dying or aid in dying, death with dignity, and end-of-life care is a much broader topic that sometimes gets subsumed under that. It differs from euthanasia. Euthanasia is the act of directly causing death, usually by an intravenous injection, rather than providing medications for a patient to self-administer. Euthanasia is banned in all of the United States, but in fact is legal in what are called the Benelux countries, Belgium, Netherlands, and Luxembourg. And in those countries, it's considered to be favored because it's felt to be both faster and kinder than making someone self-administer an oral medication. And just to give a little historical perspective, this is not all about question 2. I just want to give people in the audience who maybe haven't had a chance to learn about this or think about it very much, a little background on where we've been over the years and kind of how we've gotten here, but real quick, just an overview. And I started with it in the 1950s just to talk about what some of the moral requirements for physicians are. Pope Pius XII said that there was no moral requirement for doctors to provide extraordinary medical treatment. Now, this is not talking about providing end-of-life care, but not a moral requirement to provide extraordinary medical treatment. In the 1960s, organ transplantation came about as something that we could do technically, and there was a question about when do you take organs, how do you take organs, when is someone dead but their heart's still beating. And so in 1968, there was a Harvard group that developed the definition of brain death that really became accepted as the determination of death other than the traditional end of heart beating being the time of death. And that was to declare brain death. And that's different than what is called a persistent vegetative state, which is what the young woman Karen Ann Quinlan had in the 1970s. And she was on a ventilator, was being kept alive, but really had no interaction with the world. And her parents wanted to have her come off the ventilator so she could die what they considered a death with dignity and not being kept alive on a ventilator. But the hospital she was in refused to do that. So the parents went to the courts, and the New Jersey Supreme Court said that it was okay to remove the ventilator in this case. And that then set a new precedent for what could be done in end-of-life care. In 1981, the United States Congress adopted what was essentially the Harvard classification of definition of brain death in what was called the Uniform Determination of Death Act. So we had uniformly throughout the country a set definition. Before that, each state kind of had their own definition. You could actually be alive in one state but dead in another state, depending which state you happen to be in and which guidelines you were working under. So finally, in 1981, there's the Uniform Determination of Death. A bit later, in 1990, there was another young woman by the name of Nancy Cruzan, who was, again, in a persistent vegetative state, not brain death, who was not on a ventilator. She was breathing on her own, but she was being kept alive with artificial hydration and tube feedings through a gastrostomy tube. And her parents wanted to withdraw her from that, feeling that, again, this wasn't really their daughter. She wasn't staying alive in any way that was meaningful. And so they asked the courts to withdraw this artificial hydration. And again, the courts upheld this, that it was okay to withdraw artificial hydration and artificial feeding that was sustaining someone in a persistent vegetative state. And again, in 1990, Congress passed the Patient Self-Determination Act, which is the right for all of us to prepare an advance directive. So we can tell people what we want when we're in a state like Cruzan or Quinlan. Also that year, Jack Kevorkian performed his first assisted suicide, which was really euthanasia-like. It was intravenous injection of a combination of medications that would lead to death, although it was rigged up with a machine that the patient triggered, but it was very close to being euthanasia, that it was intravenous injection. And around the same, so Jack Kevorkian got this, I think, well, I'm supposed to be the moderator, not one side or the other. But I think lots of people really questioned what Kevorkian was doing and considered that perhaps way beyond just physician-assisted suicide and perhaps out-and-out killing. But at the same time, another doctor, Timothy Quill from Rochester, published an article in the New England Journal of Medicine where he admitted to having helped a patient who had leukemia and was refusing treatment, was dying, was going to die without any treatment for leukemia, and she asked for some pills to help her die more peacefully, and he provided those. And he wrote this to the New England Journal of Medicine, and I've heard Marcia Angel, who was the editor at the time, talk about this, and she called up Dr. Quill and said, if we publish this, you're going to be in big trouble. This, physician-assisted suicide is not allowed in New York State. You're going to be in trouble. And he said, go ahead and publish it anyway. She did. He got arrested for assisting suicide and then was acquitted by a jury. He's gone on to be a leader in the field of physician-assisted suicide and or death with dignity, however you want to call that. His case and others, another from Washington State, came before the Supreme Court in 1997. It got argued up to the courts. And the court said the court said that physician-assisted suicide is not a constitutional right, but the states can make their own determination. So we're a little bit back to where we were almost with the, before we had the uniform definition of what death was. So different states can do different things depending on their own constituents. So what do other jurisdictions do? Well, again, I said already that physician-assisted suicide is legal in the Benelux countries. It's also legal in Switzerland. It is not legal in England, although they are talking about it. And there are physician-assisted suicides that occur there that the chief prosecutor chooses not to prosecute on a case-by-case basis, but there's no clear law on that. The key here in the United States is that in 1998, Oregon enacted a legislation very similar to what is in front of us in Massachusetts now, and I know our panelists will be talking about that. In 2009, Washington State did also. Again, in 2009, the Montana Supreme Court permitted assisted dying. It wasn't a state legislature act, it was a court. And again, a court in British Columbia, Canada, just this past year, overturned a law against assisted dying. So there's a lot going on north of the border for us now, too. So all of us, when we talk about ethical considerations of something in medicine, we talk about autonomy, the patient's right to determine things, beneficence, doing well by the patient, non-maleficence, doing no harm, and justice. And so we have the autonomy of both the physician and the patient at stake here in the question number 2. We have the idea of beneficence, that we're relieving suffering, but also the question of our role to do no harm as physicians. And then there's the justice, both legal justice and what's fair to people who are dying. And that's what our expert's going to talk about tonight. So what I just to lay out a little bit of tonight's format, we're going to do a pro and con here, and we're going to have about 20 minutes each for each pair of people to discuss this, and then a 5-minute rebuttal from each side, because obviously you're going to say things the others have some comments about. And then we'll take questions from the audience. So it'll be about an hour of getting going, and then half an hour to 40 minutes of discussion from the audience. What I would ask is that this is a very emotionally charged topic, obviously. What we don't want from the audience is someone getting up and giving a 15-minute monologue on their emotional feelings. Well, but there's lots of people who are very impassioned, and I understand that, and there's going to be a desire for a lot of you, I think, to say, a lot. But let's try to keep it to a question and answer for the panelists, and then any discussion you want to do beyond that is certainly you're welcome to do and keep doing for all evening, because it's an important topic. So our speakers tonight, the panelists in favor are Dr. David Clive, who's professor of medicine, former chair of our Ethics and Treatment Issues Committee, and has been an active teacher in ethics programs here at UMass for quite a few years. And also Dr. Suzana Makowski, who's a physician in palliative care medicine and runs the program here at UMass for palliative care. The panelists on the opposite side, opposed to the law, are Father William Stempsey, who's a Jesuit priest of Holy Cross. I know a number of you have had him as a professor recently. He's also a physician. And Dr. Richard Aghababian, who's an ER physician here, was head of our ER for many years and is now president of the Massachusetts Medical Society. So on that, we'll let the panelists go, and David and Suzana, you're first.
All right. Okay, can everybody hear me all right? Is this working? Great. So first, I'm just amazed at how many people are here tonight. This is a great showing, so thank you for coming. And as mentioned, this is a heated debate with a lot of personal views and values that are going to come up in the discussion. And I'd like to just put a few things out there in the beginning. One is, the ideas that I represent here tonight really are my own, and also recognize that everybody has choice, which is really what this ballot is about too. And being a member also of the American Hospice and Palliative Medicine Society Association, is that the Academy really recognizes that even among our own physicians in palliative care, there's a split in terms of which physicians would participate in this and believe that this is the right things to do, and those who wouldn't. And this ballot doesn't object to personal choice. It supports the right for each individual person to have self-determination when the time comes at this time of life. One of the arguments that I think has been brought up quite a bit in the media has been around our physician obligation to heal. And in my field, the definition of palliative care is really around the alleviation of suffering. And this is also a primordial responsibility of the physician. And I would say that the alleviation of suffering trumps in many ways the opportunity to heal, because there comes a time in each one of our lives when we will die, when we're facing the end of our lives. No matter what we do as physicians, we have not found a way to create immortality or to beat death. So there is a time when we are nearing the end of life, and our obligation of physicians is to support patients at that time the best way possible, to alleviate their suffering, and to assure that it's done in a manner that's respectful of their personal wish. Another piece that has been discussed is how this bill might affect and infringe the ability for patients to obtain good palliative care, and that good palliative care will negate the need for people to perhaps choose or want to have this potential choice at the end of life. And one thing that I've seen in having taken care of many patients who are in this setting, who I hope I'm giving as good palliative care as I can to, and I think many people in this audience have been at my bedside at the bedside with me of patients who are nearing the end of life, that there are times that no matter what we try and what we do, suffering persists, indignity persists, debility increases. And for some people, the lack of dignity that happens as disease progresses, especially as wounds get impossible to heal, as pain becomes horrific. And I throw medicines at people that I think most people in this audience would be terrified of prescribing for the name of trying to fight pain. But there are times that even I can't prevent that level of suffering. And beyond that, there are also times when the amount of suffering that occurs is not just around the physical suffering in terms of the symptoms, but the debility that patients experience, the need for a father to depend on his daughter or his son to clean up after him, to take care of him, and the burden the concern that parents have sometimes of taking away time for families when they know their children have obligations to work and their own children, that they want a choice at that point in time of not whether they die, because most people, even in that setting, want to live, but knowing that they're dying, that they have a choice as to how and when it occurs. And this ballot gives a patient that choice. There's also concern that's been raised around having people alone at that point in time. A lot of New Englanders are stoic, private people who don't necessarily want a large family around them at that time. This discussion doesn't mean that everybody has to be alone, but again, because this ballot is about choice, it gives the patient the right, given their capacity and their ability, to have the choice as to who is at their side, who's going to comfort them, or whether they wish to be alone in privacy. And I've had people in the hospital and at home say, I need to be alone at this time. Those of us who've taken care of people at the end of life know stories time and time again, even those patients who are dying and barely awake, who have had families sitting vigil day in and day out in the hospital, wait until that one family member finally steps out of the room and is at the moment of their solitude that they let go. So this aspect that the choice to do this alone is again about the choice for that particular patient. It's not a mandate, it's a choice. This is not an easy discussion. Death is never an easy discussion. How we die now with the best palliative care that we can provide, with hospice care, is usually messy and difficult and not easy, and we wish we could offer more. And this bill also is going to be difficult. It's a hard discussion. It's a hard and heartfelt consideration. And this doesn't take away from the preciousness of life and the sanctity of our wish, but it really has a role in the sense of recognizing that each person and that principle of autonomy is there to really respect the wishes of each individual. And the other piece of it is, just like I said, there are palliative care physicians who would never want to participate in this. There are pharmacists and nurses who would never personally want to participate in it. This is not a mandate. Any one of us who chooses to support someone at this stage of life in this way, should this ballot pass, and any one of us who chooses not to participate in this way, should this ballot pass, your wishes will be respected. Okay, but it wasn't working. I've known people for a long time in my life, even in the moment of health, whose values and wishes they've clearly shared with me, even in the peak of their health, that when their time comes, they want to be able to have a choice. Not before then. And this is the difference between this bill, death with dignity, and the concept of suicide. I too object to the word, this is physician-assisted suicide, because suicide really applies to an individual who has a normal life expectancy, who has mental illness, and is lacking clear judgment as to what their choices are. This is about somebody who's terminally ill and who has the wish to choose how they're going to exit this life. And as I mentioned, I've had patients who are fully healthy in a primary care clinic long before I came to palliative care, and friends and families whose values and wishes said, you know, this to me is too important. These are my values, just like I have other patients of mine. And I'll never forget one guy who says, a meaningful life for me is that you keep my heart beating. I don't care how, I don't care when, I don't care if it's the only way I get my heart to beat 3 more times is because there's a gunner, third-year med student, who always wants to do a cardiac massage on somebody, and cracks my chest open, and it hurts like Dickens, and they push their hand in my heart and just squeeze it 3 more times. That, for me, is a meaningful life. And I respect that choice, as I hope that this ballot allows other people who have a different choice of how to choose those final minutes and hours to be.
I don't think I've ever seen this amphitheater this full. I'm kind of tempted to talk about renal I want to just quickly say why I'm for the bill. And I'll point out in advance that some of these are kind of intrinsic factors within myself. Some of them are things in the environment or that I've been exposed to that have influenced me. First intrinsic thing is that in many years as a clinical nephrologist, I've had the experience of having dialysis patients ask to be, or actually tell me that they intend to stop having dialysis. This is not that uncommon a event in my field, and in some series, there have been a lot of series. It's like the number 2 cause of death after cardiovascular disease in dialysis patients is self-withdrawal. And as a rule, these patients opt to change their rather limited lifestyle and all their comorbidities that dialysis doesn't improve for a death that typically occurs in 7 to 10 days. That is rather peaceful and can be orchestrated, I guess, if you will, at home. And I think that's a good thing for them. I've often thought that the only possible good thing about having to be on dialysis is that you have an escape valve if things get too miserable for you. And as a result, I started to wonder why is it that other people don't have that opportunity? Now, I guess I would rephrase it, people who don't live in Oregon or Washington. You know, when you read about this, you learn that kind of our legal and fundamental religious teaching in the Western world is such that there is a distinction between withdrawing artificial means of life support and actively seeking death through assisted means or pharmacologic means. I'm sorry, but I find that a very thin distinction. The more I read about this, the more I see that that distinction is grounded in ideas and traditions which seem to me to be dogmatic, archaic, very abstract, hypothetical, and in any event, not really satisfactory from the standpoint of meeting the needs of the suffering patient I had. Like Dr. Makowski, I've got a lot of, not as much as you, but I've got a lot of experience in hospice. I'm actually Associate Medical Director of a hospice in Newton. And I realized that as wonderful as hospice is and as committed to palliative care as I am, there are times when it doesn't really satisfy the needs of the patient. It doesn't end their suffering. And please remember that suffering does not just mean physical pain. We know from the Oregon experience and the Washington experience that the far majority of patients who opt for assisted death don't do it because of pain. They do it because of limitations and losses of things that make life for them worth living. We can't always, even with the best hospice care in the world, we can't always meet those needs for patients or alleviate those kinds of suffering. And I also think that, and again, this is another intrinsic, core belief of my own, that it's really not up to anyone else to determine what qualifies as a acceptable quality of life for anyone else. And by the way, that's not only my own belief, that's one of the core principles of medical ethics, is that it is the patient themselves who have to, who can evaluate quality of life when we develop that calculus to determine an end-of-life care decision. So others who say, well, this is just opting for people to take an easy and convenient way out, I think they're overstepping their bounds. It's really the patient expressing that authentic and durable wish to have their life end, who is solely in charge, or should be solely in charge of that decision. The way this bill is written, that's how it works. Some of the external things which have affected me. Number one, with all due respect to my friend and longtime colleague, Dick Aghababian, and others on his side of this issue, whom I have endless respect for and I value as friends. The more I read of the arguments against Death with Dignity Acts like Bill number 2, the more resolved I find myself becoming that our position is the right one, and I feel much stronger and much more comfortable with that decision. I'm not going to get into why that is now. I think there'll be, perhaps as the discussion evolves, there will be a chance to do that. Lastly, the last extrinsic thing that has affected me is the Oregon experience, which Brian alluded to.
You want that slide up there?
Yeah, that'd be great. We've had a pilot study done. It's been in operation for 15 years. It has, in Oregon, 30,000 people die every year, and every year, fewer than 0.3% opt to have their life terminated under the provisions of the Death with Dignity Act. Slight increments from year to year, but they have been slight. And the reason they're going up is probably just because of the fact that the bill is out there and people are becoming more familiar with it. Not because we're getting more promiscuous about who we allow to have physician-assisted death take their lives. The experience there has been that the medications are quite effective. I'm going to leave it, I think, at that. I just want to just point out that what you're seeing here is the Oregon experience over the first 14 or so years of its existence, from the time it was went into operation in 1998 up through 2011, which is the last year for which we have complete data, obviously. And the blue bars show the number of people who have had prescriptions written for them. The green bars show the number of people who actually took the medications, most of whom successfully were able to end their lives in that fashion. The numbers you see at the top, which range from 29 to 31, those are the total deaths in thousands in Oregon. So if you factor that in, you'll see that this is not by any stretch of the imagination, an oversubscribed process. So I'm going to leave off here. I guess now we will hear from the opposition.
So, thank you very much. You guys are very succinct, and there will be time for some back and forth, hopefully, after this, before we get to the audience participation. Dr. Father Stempsey, do you want to say a few words now? And then Dr. Aghababian.
Thanks. Happy to be here with you today, and to see you to my former students. My medical training was in pathology. And as I've become kind of the anti-Kevorkian now. I haven't practiced in quite a while. I joined the Jesuits. I was ordained a priest and had some experience with hospital chaplaincy, as well as doing a lot of thinking about medical ethics issues. I got a PhD in philosophy and philosophy of medicine, medical ethics along the way about 17 years or so ago, and have been doing this ever since. I want to make 3 points here arguing against this idea. And one has to do with the physician, another has to do with the patient, and the third has to do with this notion of dignity. Forgive me, I'm a philosopher here, so I'm going to be not technical, but maybe a little philosophical. A lot of people are afraid of dying. Now, we're to some extent all afraid of dying in the existential sort of sense. We don't know what's coming up. But I'm talking about something more specific. People are afraid of dying, and they're picturing dying, yelling and screaming in pain. Other people don't want to think about it at all, but when they do think, because I think they are afraid. The other thing is that people, I think, don't like doctors as much as they used to when doctors couldn't do anything. When I was a kid, I think doctors had penicillin and streptomycin and maybe some sulfa drugs, and that was about it. And doctors would come and they would sit with you when you were sick. And people found some comfort in that. When we turn medicine into a technological kind of a thing, and lose that kind of a personal touch that we had in those old days, I think people react against that, and they don't like that. Not to say that technological medicine isn't a good thing, because it certainly is, and I depend on it myself. But you think about the kind of normal reaction you have from many people about seeing people in ICUs with tubes in them. I had this experience just this summer. My mother ended up with about 24 hours in the ICU after a knee replacement. Her electrolytes went off and she got kind of confused, to say the least. But they stuck her in there and she had, I don't know, 3 or 4 IVs and a bunch of other stuff in there. And for me, who was used to seeing this thing, to see my mother like that was a bit of a shock. So if you're not used to that, it's upsetting. And I think that people are afraid of that kind of thing. I'm afraid that making, legitimizing this idea of physicians assisting in death will play into those kinds of fears. Second, the doctor's role. The doctors now, I don't think we'll find any disagreement about this, no matter what side of this bill you're on. The doctor's role is to care. Now the question is, what does care entail? I don't want to say that that assisting in a patient's assisting a patient to end the patient's own life is an easy way out. It's not an easy way out. I don't think anybody's seeing this as easy. But I am worried that frustrated doctors might capitulate to requests too easily. You think about this, you're trying to help a patient to relieve suffering, and you're being frustrated because your drugs aren't working. I'm not saying you're consciously going to do this, but it is something you might grasp at as the only possible way to help that patient get out of that suffering. And I'm not sure that that's what medical care is all about. Edmund Pellegrino, who was actually one of my teachers in graduate school, once described physicians as ordinary people faced with extraordinary tasks. Ordinary people faced with extraordinary tasks. That's certainly true. And I'm just worried about leaving such momentous decisions to help patients out in this way to ordinary people. What medicine is about, I think, is compassion. And compassion has a lot to do with staying with people in their suffering, even when sometimes we're powerless to alleviate, to at least eliminate that suffering. When I was working as a chaplain once, I was at the old New England Deaconess Hospital back before the big merger in Worcester. And they, of course, were associated with the Adult Diabetes Center. So we saw in that hospital a lot of people with the worst sorts of complications of diabetes. And there was a man I would go, this man was in the hospital for months, and I would visit him every day. And he had first one leg amputated and the second leg amputated. And then one day I went to see him, and I learned that his wife had been in visiting just an hour before, and that she was killed in a car crash on the way home. And that man just clammed up. He wouldn't talk to anybody. And I went in to see him every day for probably a week or 10 days. And I just sat with him. I didn't sit there long, but I would go in and sit there for 5 or 10 minutes and just say, I'm here, I'm going to be with you for a while. And he would just kind of stare blankly at me. Then one day, he talked back. He said, I want to thank you for coming in here. I can't tell you how much that meant to me. Because I had no idea what I was doing when I was doing it. I think that says something about compassion that doctors are called to. Third point, dignity. We talk about death with dignity in terms of this bill all the time. And I think that this fundamentally misconstrues the notion of dignity. I don't want to go into Immanuel Kant and the basis for human dignity and the rational being and all that. If you want to do that, you can do it. I think there's something more down to this. Techno-medicine has become the enemy of people, and it's forced a dilemma. People sometimes say they just want to die at home, but they're afraid to die at home. I don't know how many people I've seen have brought the hospital beds in to die at home, and then if something happens acutely, they call 911, get resuscitated and carried into the hospital, against everything that they said that they wanted. But they get to that point. And death doesn't always come in a nice, peaceful way. The acute things happen, and that's what happens to you. And people don't anticipate that, and that's part of the fear. So we've got this dilemma. They want to die at home, but they're afraid to. And also, with the society today, often there are no people at home to actually give that care. Death used to be a part of life. I remember when I was a kid going to wakes where they were in the home. We've sanitized all that and put it away from us now, and we don't want to think about it. For me, this assisting patients in dying, in a way, is saying, well, dealing with all of this is just too hard. Let's give up the struggle and let's just take control. We talk all about choice. But just kind of a last point on this notion of dignity. What's the meaning of life? Here's the philosopher coming out with. I'm not going to answer this question. But look at what our society tells us today. Meaning of life is wealth, success, and youth. What do we do to maintain our youth? And control. Choice, control over things. And I think this is not what dignity is all about. Dignity is not lost with approaching death. Dignity is not lost when you wet yourself. Dignity is not lost when you have to be fed by someone. You are a human person and have dignity, and no one will ever take that away from you. What dignity points to is the need for compassion, for staying with people who are suffering. It's going to be a time, I think, to be with these people as they come to grips at just what their life has meant. If many of you probably read that little novella by Leo Tolstoy, The Death of Ivan Ilyich, where he questions whether his life, as he's dying, he questions about whether his life has been worth living. And at the end, he has this 3-day-long scream where he just screams incessantly. And it's only after letting that out for 3 days that he comes to the realization that this is his fate. And I think that is something that physicians can really, are in a privileged position to help people in those kinds of places. So I just wouldn't want to see that end too quickly.
If you don't mind, I'm going to stand while I speak. I've actually had to discuss this issue quite a bit. In the last month, in fact, last week I was at the Brigham Women's Hospital debating Marcia Angel, who was mentioned earlier. It was ironic that I actually was born there at Women's Lying In, which is the Women's Hospital. And now I'm in this auditorium where I was reincarnated as a medical student 42 years ago, under the watchful eye of Art Pappas, who's still here today. So there's something fateful about my participating in this discussion. Now, as the current president of the Massachusetts Medical Society, I'm here to share with you the policies that my fellow members and I have crafted after extensive debate on this matter. I will attempt to explain the reasoning behind our policy. And we did not arrive at our decision hastily. We had considerable debate, but in the end, the vote clearly demonstrated a lack of support for physician-assisted suicide. I believe, however, that we all came away with respect to both sides of the issue, and I haven't heard anything from either side today or tonight that is disagreeable. The description of our position on physician-assisted suicide has been posted on the Mass Medical Society website and mailed to all physician members in Massachusetts. We all understand that medicine's treatment of patients at the end of life remains problematic. For example, a disproportionate amount of the healthcare dollar is spent during the last year of life. Some feel a portion of that money could be used more wisely in other ways. The so-called death panel debate 3 years ago, unfortunately, short-circuited any meaningful discussion at a national level about end-of-life care. Pain at the end of life may not be properly reported by patients or fully appreciated by physicians. Therefore, treatment may be suboptimal. The use of hospice services, where available, may not be requested by physicians or utilized by patients. As the end of life approaches, family members can be at odds with each other and sometimes even at odds with a terminally ill patient. They may demand the continuance of futile care. Patients may have neglected to make end-of-life issues well known to their doctors and their family members. The Massachusetts Medical Society recognizes that there's a lot of work to be done, and not just by those of us in medicine on this issue. However, these shortcomings do not justify support of question 2. They compel us to improve end-of-life care, not abandon efforts by making patients feel that suicide is a viable option. I want to outline the 5 principal reasons for our opposition to question 2. Reason 1. The first reason, the proposed safeguards in the legislation are not sufficient. The safeguards may sound impressive, but there are several loopholes that are troubling to us. There's no provision to enforce the proposed safeguards, and there is no oversight of the process. Only a statement that punishment will follow criminal behavior. There is no authority given to any state agency to investigate suspicion of wrongdoing. The only check against abuse is the opinion of the prescribing doctor, which puts the physician in the role of both being caregiver and law enforcement officer. This is not appropriate. Worse, physicians are held to a good faith standard. This makes any or all of the safeguards unenforceable. Another issue is the fact that the witnesses to the patient's signing of the document declaring his or her will to implement this procedure may be an heir of the patient. This opens the door to the possibility of abuse, even though one of the other witnesses may not be an heir. Why allow any heir to be a legal witness to the signing? And finally, there is no requirement that there be an independent witness to the administration of the legally prescribed medication. Issue 2. The second reason for opposition to the question is that assisted suicide is not necessary to improve the quality of life at the end of life. Currently, a patient is legally and ethically free without assistance to refuse life-saving treatment, as we've heard, or to insist on adequate pain medication. You are allowed to do that. They need no one else's help to do so. If the patient is unable to speak for himself or herself, a healthcare proxy can do it on their behalf. Proper advance directives, as we have heard, which are legally binding in Massachusetts, can address many issues about quality of life at the end stages of the disease. Let me show you the statement my wife and I signed 18 years ago as part of our state planning. This is after the law was passed in Massachusetts. We made it very clear what our wishes are. We don't want to be kept alive artificially just to be sustained, and that we want to be adequately treated in life. I'm not going to read it for you. Palliative and hospice care services are wonderful resources that are not utilized at any level close to their potential. Professionals in hospice care are very skilled, very compassionate, and very wise. They serve both the patient and the patient's family, and they do so very well. Both my wife, Ann, who's in the audience, and I have had very favorable experiences with hospice care while caring for our own parents at the end of their lives from natural causes. With the framework of an existing patient-physician relationship and with appropriate documents in hand, a physician will understand the wishes of the patient, the concerns of the family, and should address these issues with great compassion and professionalism. As of today, over 98% of Massachusetts residents have health care insurance. 90% or more have a primary care physician, and over 80% of the people in Massachusetts have seen that physician in the last year. And approximately one-half of the Massachusetts primary care physicians are still taking new patients. So there's no reason why a patient with a diagnosis of a disease that may end their life shouldn't have a physician to provide health care, treatment, and guidance from the time of diagnosis to the end of life, or before time of diagnosis. In an attempt to improve physician skills that focus on end-of-life care, the Massachusetts Medical Society and many other providers at CME are increasing efforts to provide effective educational opportunities that address this subject. The third reason for opposing the ballot question, physicians' ability to accurately predict the time of death is uncertain. I think everyone in this room knows how difficult such a determination can be, especially in complex patients with multiple comorbid conditions. The bill specifies that the patient should have 6 months or less to live. It's very difficult for a physician to predict with accuracy when a patient is expected to survive just 6 months more due to their condition. A Harvard physician, Nicholas Christakis, recently found that 17% of hospice patients he studied outlive their diagnosis. This research supports what many suspect. It is very difficult to make such predictions. Fourth reason, as the most recent Mass Medical Society president, Linda Young, who preceded me, has stated previously, physician participating in assisted suicide is fundamentally at odds with our duty as healers. The legislation allows physicians to opt out of practice opt out of this practice for reasons of personal conscience, and Susan mentioned that. But when even some members engage in this activity, it affects all of us, and fundamentally changes the dynamic of the patient-physician relationship. It may introduce the seed of doubt in a patient's mind about the motives of the physician. In fact, several advocacy groups for disabled patients, including a group called Second Thought, are very worried about that this could put them in a vulnerable position and introduce the possibility of coercion or fraud. They maintain these are vulnerable populations and they deserve unqualified protection. You may or may not agree with this concern, but it illustrates the point that patient-physician relationship gets very complicated under a scenario where a physician-assisted suicide is legalized and enshrined in state law and case law. Massachusetts already has a strong vehicle that gives patients the ability to make their wishes known. You saw my wife and my advance directive. The advance directives are legally binding and be as specific as the patient wishes. As I have stated, often they are communicated by a healthcare proxy examples of which, by the way, are available on the internet. And in fact, healthcare proxy forms have been one of the most popular pages on the MMS website for many years. Dave showed us an overview of the Oregon data. As physicians, it's important for us to evaluate reliable data, and this is reliable data from the Department of Public Health in Oregon, before we make clinical decisions. So let's look at the Oregon data again. And what I did was I drilled down a few particular areas that weren't being discussed on a regular basis. This chart shows that the underlying illness for those who ingested the medication, you can see cancer was far away the most common reason. The median relationship between the patient and the physician was only 12 weeks. This suggests that a large number of patients may not have had a long-term relationship with a physician who managed the terminal illness that was ultimately stated on the death certificate. This suggests that a large number of patients were cared for by a physician who specialized in providing suicide services. Do we really want to foster the growth of this kind of a specialty in Massachusetts? This is not the kind of doctor-patient relationship that the MMS and the people of Massachusetts have been striving for in our healthcare reform initiatives dating back to 2006. The next data point is that only 7% of the patients were referred to a psychiatrist for evaluation, even though it is well documented that a terminal illness is often accompanied by depression. And the prescribing physician is present at death in only a minority of cases. In fact, in 2001, no provider at all was present in 9 out of 10 cases. The median time between ingestion and death typically is brief, but the range is very broad. Perhaps a little too broad to be acceptable. We always have to look at any intervention that has untoward side effects. And there have been serious treatment complications. 22 patients regurgitated after taking the medicine, which, by the way, is Seconal, 100 tablets that you're supposed to dissolve in water and drink quickly. And 5 patients regained consciousness after taking a drug that was supposed to kill them, the suicide gesture. In one case, a patient regained consciousness 88 hours after ingestion. Did these individuals receive humane end-of-life care?